Thanks, Anna, for this nice introduction and the great honor to kick off today's very interesting session. As Anna already said, I'm going to focus the talk on syndromic panel PCRs in joint infection. And these are my conflicts of interests. And although joint infections are probably not the most common disease, with native joint infections having 4 to 10 cases per 100,000 patient years, and in PJIs, more or less 2% to 2.5% of all arthroplasties becoming infected. It's still a very relevant disease since it has a very high morbidity and mortality, and is also often related with a high surgery rate, and obviously all the problems related to that. And it has been already obviously relevant in the past, but it's still predicted to become even more relevant, as shown here, for example, in data for the US. As you can see here, this spans up until 2030. And the PJI numbers are gonna rise there, and this could also be published for the UK and also for Germany. And this is obviously due to the demographic change, since the society is getting older and older. More arthroplasties are going to be performed, and therefore obviously also the number of PJI cases are going to rise, making this a very relevant disease also in the future. And especially in joint infection, pathogen identification is key. But why is that? Because sometimes a joint infection also represents itself clinically unclear. So if you have a swollen red joint, it can be obviously a joint infection, but it can also be, for example, gout or rheumatological disease. Especially in PJI, you need long antibiotic therapy, and this is obviously associated with adverse drug reactions and selection of AMR. And as I already mentioned, surgery with long hospital stays and obviously a high morbidity for the patient. And obviously, we as microbiologists, we always like to identify the pathogen, but this is unfortunately not so easy in joint infections, as this data shows here that in prosthetic joint infections, 5 to 34% remain culture negative, and in native joint infections, even 15 to 60%. So there's a huge identification gap going on. And as I said, and Anna also introduced, I'm a microbiologist, so you know we like to smear stuff on agar plates and simply see what grows. But there has not been so much development going on in the recent years. Yes, there might be probably some optimization if you sonicate the samples, for example, or put the synovial fluid into blood culture bottles, but still we have this identification gap. And here the non-culture-based techniques are coming into play, like namely real-time PCRs, or grouped together as syndromic panel PCRs, 16S rDNA PCR followed by sequencing, and also metagenomics, although this might be still a little bit in the future. And as we gather more and more data, also the complexity of data is rising. And this is important for the clinical microbiologist to continuously adapt to new algorithms and also adapt them to the latest scientific evidence, but also to help the treating clinician with clinically meaningful interpretations of these novel technologies and the additional data gathered. So today the talk is going to focus on syndromic panel PCR. And if one looks into the literature, here the sensitivity ranges from 60 to 100%. And the specificity around 95 to 100%. It obviously has a faster turnaround time versus culture, but there are important caveats, like, for example, a limited panel spectrum. So obviously, like for any PCR method, you only can find what you're looking for. So in different settings, the performance might vary, and this is also, for example, explanatory for the big range in sensitivity we are seeing here, if, for example, off-panel pathogens are encountered. So it's not only important to look, obviously, how these panels are performing, but also how does this translate into clinical impact. And especially with syndromic panel PCRs on synovial fluid, data on clinical impact is very sparse. But that's why I would like to dive a little bit into today in a recent publication we had together with the orthopedic surgeons at our hospital, where we focused on real-life performance and gathered data on really time to result in a real lab setting. And we also analyzed then the impact on patient or antibiotic management. So just to present quickly our cohort, we had 165 synovial fluid samples from 160 different patients, and 57% of those came from native joints. And here we could identify in 12.7% of the cases cultural growth. Whereas on the other hand, we had 43% prosthetic joints, and there we could identify pathogens in 21.1% of the cases. And looking at the time to result, it was much faster with the species-specific syndromic panel PCR. So it took 35 hours on average from really sample arrival to ID via MALDI-TOF in the lab, and only 14 hours to species ID via syndromic panel PCR. So this is already obviously good and reassuring, but obviously we wanted to look a little bit deeper, especially in the cases where the culture remains negative, as we already identified this as a main, let's say, negative point of the culture, but where the syndromic panel is positive. And this was in our cohort in 11 times the case. And this was 6 times in prosthetic joints and 5 times in native samples. And here, as I already mentioned, interpretation, it's obviously important to dig a little bit deeper if these are just, for example, false positives. So we had a closer look into that, and 8 results could be corroborated by either species-specific PCR, 16 srDNA analysis, or other microbiological findings, for example, in follow-up tissue specimen. And only 3 results, as you can see, couldn't be further investigated due to a lack of more synovial fluid. And then one could also ask the question, why was that the case? And we could also see that in culture negative samples, 72% of patients received antibiotics prior to sampling, whereas in culture positive samples, this was only 33% the case. So, as one could have also might expect it, if you apply antibiotics priorly, then it hinders the identification via culture. And we also said we wanted to look a little bit into treatment optimization. So actually first, we had also a retrospective study going on where where we also had synovial fluids analyzed. And there 66% of patients received adequate therapy in the beginning, and all of which were optimized after AST availability, which took obviously on average then usually 48 to 72 hours after arrival to the lab. And this was, at least for us as a microbiologist, reassuring that also the clinicians are actually acting on the results we are providing. And back to the prospective study, here we could see that in 28.9% of cases, the treatment got either de-escalated to an optimal therapy or immediately started with an optimized treatment based on the syndromic panel PCR results. And obviously, this also happened quicker than waiting for the culture. Also, obviously, there are important limitations. So we didn't have this embedded in an antibiotic stewardship workflow. We, as clinical microbiologists, called the treating clinician with a positive result. So if this could have been embedded somehow in an antibiotic stewardship intervention, the outcomes might have been even better. And the treatment optimization is only based on ID is only possible in a limited amount of cases, for example, MSSA, RSA, or beta hemolytic streptococci. But for example, if you find Enterobacterialis, you cannot really adjust the therapy just on the ID alone. So still phenotypic AST remains crucial. And as I already mentioned before, in specific settings, like for example PJI, where there might be other species which are, for example, off-pan, like Cutibacterium species or Coagulase negative staphylococci are encountered, obviously the performance of the panel might also be worse. And we didn't really investigate any further clinical impact like morbidity or mortality, so future studies are for sure needed. And to put this all into like a bigger picture of the diagnostic and antibiotic stewardship, obviously in molecular tests, we want to increase the diagnostic yield, so the rate of true positives, but avoid overdiagnosis like false positives. And so when trying to implement new, for example, molecular techniques, one has to think about, for example, strict GO criteria to identify cases eligible for molecular assays, which, for example, in diagnostic stewardship language would be the right patient, or define staged procedures like reflex assays. So, for example, one test is positive or, I don't know, very high cell count, then we are doing this. So this would be the right test. And to simply have as a major goal an increased a priori probability of assay positivity and a real added diagnostic value. And this is actually, for example, from Azad et al., a proposed workflow where you can still see the culture is still above of all. But then in a certain subset where, for example, the culture then really remained negative, but one still has a high suspicion of joint infection, then one could apply, for example, syndromic panel testing or 16S rDNA. So there are obviously different approaches, or even here mentioned as the last line, metagenomic approaches. And interestingly, in a recent guideline update from 2023 of the septic arthritis guideline, here it's also recommended to use molecular polymerase chain reactions in people taking antibiotics or negative cultures are encountered with a high suspicion of joint infections. And this is still unpublished data, but keep an eye out for this one in the next couple of weeks, hopefully. Really great work by Marjan and her colleagues, unified PJI criteria. And also here it's mentioned throughout the manuscript to use molecular approaches in culture negative samples or people who had prior antibiotics applied. And also the identification via molecular test in either tissue or synovial fluid or sonication fluid is going to be a supportive criteria for identification of a PJI. So to sum up, culture-based techniques still remain the gold standard, but molecular tests serve as very important supplementary tools. Here first we're thinking about PCRs, and NGS is so far at least still restricted to a subset of cases. One has to keep in mind that there are obviously formal and regulatory affair still to be addressed also in beforehand. So standardization of protocols, for example, this is in my eyes at least very important for NGS approaches. Then IVDR, FDA approval, and also important reimbursement by health insurances, since the more complex assays you apply, also they're obviously not cheap. And as a diagnostic pathway in the newest guidelines and criteria, it's mentioned that molecular techniques should be employed in patients on antibiotics or culture negative suspected joint infections. And it's in my eyes, very crucially important to have it implemented in antibiotic stewardship and diagnostic stewardship workflows, and also provide a close exchange between the different medical disciplines working on that patient to have the optimal interpretation, but also usage of the system, and to then ultimately have the best effect for the patient. And then I would like to end with a call for all of you listening. So far there are little studies really on this clinical impact. So please go for it, gather evidence, and yeah, that would be very, very helpful to know when to use these assays and if it's actually really worth it. With this, I would like to thank my institute, especially Holger Rode, Martin Epfelbacher, Konstantin and Laura, and also other collaborators from the trauma and orthopedic surgery, Ola, Johannes, Tim and Lucas, and obviously all the other collaborators and other former and current members of the institute. And thank you for your attention. Thank you.